Chitra, for that introduction. And I think every ophthalmologist here in the symposium is very well admired and appreciated. Okay, going on for the filtering surgery and its role in glaucoma management. Now, the filtering surgeries are essentially were full thickness about 100 years back, and then they had become guarded filtration procedures. And other filtering procedures include tube shunts, and recently, minimally invasive glaucoma surgeries have become the order of the day, usually in management, initial management at least, of mild to moderate glaucomas. Now, trabeculectomy is by far the gold standard primary glaucoma filtering surgery, and it lowers intraocular pressure by diverting the aqueous into subconjunctival space from the anterior chamber, and alternate drainage to bypass the poorly functional aqueous outflow pathway. And it is one glaucoma filtering procedure like the tube shunts, which can overcome obstruction at the level of trabecular meshwork, Schlemm's canal, aqueous veins, scleral channels, and episcleral vein pressure elevation. Now, the indications are when there is documented visual field and optic nerve damage in spite of maximum tolerated medical therapy and laser, and there is failure of medical therapy owing to several reasons such as ineffectiveness, intolerance, allergies, poor adherence, or complications arising out of medical treatment. And in general, when intraocular pressure is high enough to cause progressive optic nerve or visual field changes, trabeculectomy is indicated. Now, when we think of outcomes, we need to be very careful about choosing the eyes and patients who would favorably respond to trabeculectomy. These include essentially the primary glaucomas with virgin eyes in which conjunctiva has been untouched. There has been no prior ocular or conjunctival surgeries. And even in certain eyes in which have not undergone surgery, if there is significant conjunctival scarring due to surface ocular disease or other causes, and if there has been long-term glaucoma medical therapy, which can cause significant conjunctival inflammation, ocular inflammations, neovascular glaucomas, iridocorneal endothelial syndromes, and secondary developmental glaucomas can all compromise a very favorable outcome in case of trabeculectomy. Now, preoperative considerations, as apart from the eyes which need to be selected carefully, we also need to ensure adequate and appropriate anesthesia is administered. All kinds of anesthesia can be preferred depending upon the individual needs. And most preferred and the safest probably is topical. Topical is not like what you would see in cataract surgeries where only topical drops are used, but it is combined with intracameral lignocaine and subconjunctival infiltration of lignocaine. And for several reasons, this is advantageous and more safer than peribulbar, retrobulbar, and what we commonly follow in our institution is subtenons. Now, traction suture. Now, if you are not using topical anesthesia, when you can obtain adequate exposure of the superior sclera and the conjunctiva, probably you may have to go in for traction sutures. The most popular ones have been these, the bridal suture, superior rectus bridal suture. But the problem is you are violating the conjunctiva. There could be bleeding, subconjunctival hemorrhage, which can actually compromise the success of trabeculectomy. Alternative is, of course, the corneal, superior corneal suture, traction suture, which can actually obviate the complications which one would see in superior rectus bridal suture, and probably you would get adequate exposure as well. It minimizes the conjunctival trauma and probably the risk of postoperative ptosis. And there are studies to prove that corneal traction sutures may probably result in better surgical outcomes. The conjunctival incision, both fornix-based and limbus-based, are possible, but the outcomes as far as intraocular pressures are concerned are probably comparable between the two approaches. What we usually prefer is the fornix-based conjunctival flap because it is extensive exposure one could get, and the visualization one could get. Very little assistance is required from a second a nurse or a nursing assistant. And what is most important is you can get very diffuse blebs with fornix-based flaps and cystic blebs, focal cystic blebs, avascular blebs leading on to blebitis, bleb-related infections, which are very common with limbus-based flaps, are very, very uncommon in situations where you use fornix-based flaps. Antimetabolites, again, to increase the chances for surgical outcomes because of improvement in the wound healing response. But there could be complications if use of mitomycin and 5-fluorouracil is little injudicious. They could lead on to thin avascular blebs, cystic blebs, and complications of all overfiltration like the bleb leaks, hypotony, increased incidence of blebitis and endophthalmitis are all common. So we need to assess what is the risk involved in bleb fibrosis and use exposure of mitomycin and the dosage of mitomycin that would be very appropriate for the risk involved. Another alternative route of administration of antimetabolites would be a subconjunctival injection, and the studies have also shown that the results between subconjunctival injection of mitomycin or subconjunctival sponge application of antifibroblastic substances have been quite comparable. The injections we use commonly use these days because it's much more easier. Now, the scleral flap dissection can be done in any shape as one desires and thinks it is convenient. Usually, we use the rectangular or the triangular flap. Triangulars are much more easier. And this one thing we need to importantly remember is that the scleral corneal pocket which we try to create with the crescent blade needs to be of uniform thickness, so that you try to raise a very not so thin or a very thick scleral flap. And you need to really make sure that it is of uniform thickness because complications are possible at this stage which can compromise the outcomes. One, if the thickness is very if it is very deep, you can prematurely enter into the choroidal space, or if it is thin, very thin, especially close to the limbus, it's possible to buttonhole the scleral flap, in which case you may have to totally abandon the site of trabeculectomy and shift to another site. And very rarely we can get this thin or perforated scleral flaps after completing the trabeculectomy, in which case it's very, very difficult to get an eye with adequate intraocular pressure, and we may have there may be overfiltration. The leak may not be able to be controlled, and we need to go for scleral patch grafts. This is just to show the triangular flap, which is equally easier to do compared to rectangular flaps, but you need to take the same amount of care which you do when you take a sclerocorneal pocket in any other shape. Anterior chamber paracentesis prior to you enter the anterior chamber is very important, so that you try to decompress the globe, and the intraocular pressures within the eye are near normal to that and equalizes to that of the atmospheric pressure. So that sudden decompression can lead to a lot of complications, including suprachoroidal hemorrhage or choroidal effusions. The anterior chamber entry is the next step, and you do it with the Kelly sponge. And you need to, again, at this step, we need to be very, very careful that we do not perforate the scleral flap. And once the anterior chamber is entered, you inflate the eye, anterior chamber of the eye with the balanced salt solution, and the internal sclerostomy can be done with a Kelly sponge. Sponge is rotated perpendicular to the scleral bed, and it is, although it is called trabeculectomy, it is not necessary that we have to really excise a portion of the trabecular meshwork. In fact, a portion of the peripheral cornea, if it is excised to create a nice 1 square millimeter opening, it is sufficient to allow egress of aqueous from the anterior chamber. Peripheral iridectomy is definitely important step, especially in phakic eyes, to prevent closure of the internal sclerostomy and also to prevent any inflammatory postoperative pupillary block. The scleral flap is again another important step. It needs to be watertight. There are several ways of closing. One is just closing it with fixed sutures of 10-0 nylon. Alternatively, we can also go in for several releasable sutures. So the idea is to ensure that the scleral flap closure is very airtight, so there is no overfiltration in the immediate postoperative period, because this can cause several complications, including choroidal hemorrhage, and persistent hypotony can also cause a lot of complications. Equally important is the closure, because whatever is coming out into the subconjunctival space should stay there, so that excessive fibrosis does not occur. So it's important to close the conjunctiva airtight. You usually do it with either Vicryl, or it can be even done with the 10O nylon. But what is important is several eyes can have postoperative leak through a fornix-based flap. So it's very important that even the free edge of the conjunctival flap here is closed with 10-0 nylon until sufficient healing occurs, so that there is no early postoperative leak. So postoperative medications would include topical steroids tapered over 3 months ideally, topical antibiotics until the release of sutures, usually for a period of a week to 10 days. And in all phakic eyes, we usually prefer mild cycloplegia, especially if you prefer to do a trabeculectomy in eyes with angle closure glaucoma and leave behind the lens. Atropine for a few weeks is a must to prevent shallowing of anterior chamber and aqueous misdirection, which these eyes are at very high risk of. Assessing post-operative filtration is very, very important, and we need to, the first 3 days or 72 hours is very, very crucial, because most of the wound healing response and Bleb fibrosis starts to occur within this interval. And it's very important to have a close watch on the level of intraocular pressure, the Bleb appearance, anterior chamber depth, corneal clarity, and retinal evaluation in the first post-operative week. Now, post-operatively, when there is low intraocular pressure and a low filtering Bleb, it's usually due to leaking or blebs or wound leaks through the conjunctiva, which needs to be fixed immediately, if either through tissue glues in the outpatient, or we may, if the leaks are large due to conjunctival buttonholes, we may have to take the patient to the theater and resuture the leaking wound. Sometimes choroidal effusions, if they are not involving the posterior pole, they could be observed with conservative treatment. And of course, there is always some initial inflammation which can cause low intraocular pressure, which usually settles down with steroids. Very rarely, cyclodialysis can cause very low intraocular pressures postoperatively. Again, a high intraocular pressure with a low Bleb and a deep anterior chamber is usually due to underfiltration. This is the most another common complication, or not complication, or an adverse event which we normally see, and we need to fix it early so that long-term outcomes are sufficiently good. This situation can arise out of tight scleral flap closure, or early episcleral fibrosis, or internal sclerostomy closure. Now, the tight scleral flap closure can be either due to tight sutures per se, or due to early episcleral fibrosis. And this you can deal with slightly increasing the topical steroids. And if they do not respond, probably we should go in for release of the sutures, if they have been releasable sutures, or use argon laser or any other semiconductor diode laser to lyse the sutures, and which can actually enhance filtration to a significant extent. If this procedure fails to lower the intraocular pressure, we usually add glaucoma medications, generally topical aqueous suppressants, one or a combination, to ensure the pressures are low. And in case this does not happen with late Bleb fibrosis, we may have to go in for a needling of the Blebs with adjunctive mitomycin. Very rarely, long-term failure of filtering Blebs is an indication for repeat trabeculectomy or tube shunts. So in summary, selection of eyes not at risk of failure is important when you are performing a primary trabeculectomy. Discontinue medications causing conjunctival inflammations, principally prostaglandins. Prior to use, you may even use preoperative steroids for a few days to increase the chances of wound healing favorably. Reduce preoperative intraocular pressure maximally, so that risk of choroidal hemorrhage and effusions are minimized, and meticulous technique to avoid overfiltration, and a very close follow-up, perhaps once a week for the first few postoperative weeks is crucial to enhance filtration. Thank you.
Thank you very much, Dr. Krishnadas.